just introduced the first speaker, Professor Jason Yam from Chinese University of Hong Kong. So he's going to share atropine in controlling progression of myopia. Jason.
Thank you, Professor He and the Chair for very kind introduction. And it's my great honor today that I can share with you some of our work with the audience on low concentration atropine for myopia control and prevention. Should I stand over there? Okay. I need to stand here. Okay, so it's my great honor to share our work with the audience on the low concentration atropine for myopia control and prevention. So there's some question that I want to share about our YAM study to answer, including from whether atropine is working against placebo, is whether effective, are there any concentration dependent response, what's the optimal concentration, any effect on cornea lens power, any factor associated with the treatment, and biomarker, and whether we need to stop treatment or continue the treatment, rebound effect, etc. So we have published some papers on the YAM study. So in the first year report, we demonstrate low concentration atropine is working effectively compared to placebo group, and also there is a concentration dependent response. In 0.05% atropine, roughly it is 70% efficacy. 0.025% is roughly 50% compared to the placebo, where 0.01% is roughly 30%. And the side effect wise, of course, in terms of the photochromatic glasses usage, progressive glasses usage, and photophobia at 1 year, all groups are relatively similar, and also the visual function questionnaire is also similar across all the group. In the second year, we want to continue to see whether the second year is doing better as demonstrated in the ATOM2 study, and then to see whether this concentration dependent response remain. However, in our YAM study, we found that this concentration dependent response remains similar, and over 2 years time using 0.05% atropine, the efficacy is double that of 0.01% atropine. And we also look into other effects to see whether there is any cornea lens power effect, because at that time the discussion is whether there is some effect on the cornea and lens power in addition to the axial link. However, in our biometric study, we demonstrate that in fact only axial link have a significant changes, whereas the cornea and lens power do not have any differences. And that is important because we demonstrate low concentration atropine has no effect on cornea and lens power, but the effect is on the axial link elongation. And we also look into the treatment factor. What are the treatment factors that determine us on how to use the atropine? Here we can see, in fact, it's age. Age is important. In this scatter plot, you can see, in fact, the in all group, the younger the age, the poorer the response, the older the age, the better the response. Interestingly, if you are at age 4 using 0.05% atropine, it equal to age 6 using 0.025% atropine, and equal to the age of 8 using 0.01% atropine. So in addition to the concentration dependent response, we also demonstrate age dependent effect. Younger children, because of that inherent faster progression rate, so we need a higher concentration to achieve a similar efficacy as older children on lower concentration. And therefore, when you see a children at a young age with an earlier onset, you probably need a higher concentration. And also, it is more tolerable for younger children because of their higher, larger accommodation reserve. And in the third year, we want to answer a question whether we need to stop treatment at the third year, because based on ATOM2 study, the protocol, many people will start to think whether after 2 years we need to stop the treatment. So in the third year, we evaluate half of the group continuing the treatment and another half to stop it. And this is a second randomization. And then what we demonstrate is in all groups, continued treatment is better than stopping treatment at the third year. And also we look into the rebound. The rebound, there's two factor determine. One is the age. Younger the age, the more the rebound. The older the age, the less the rebound. When you have 1 year later to stop the treatment, in fact, you have around 0.08 diopter, 0.008 diopter less. And also the treatment concentration also associated with the rebound, but 0.05% and 0.01% clinically is not very significant. And and the third year, we suggest that we stop the treatment at older age, lower concentration, and also we in the third year we suggest to continue the treatment. So in the phase 4 report, we look into the 5-year results, and what we look into is for those who have stopped treatment at the third year, we want to see how they are responding, whether they need to restart the treatment or not, and if they restart the treatment, what is the efficacy. And roughly, in fact, for all these children, 90% of them from year 3 to year 5 need to restart the treatment. And also for those who restart the treatment, older age is better for those who have a higher chance of a successful cessation of the treatment. And we also see that, in fact, during a placebo projection model, 0.05% atropine over 5 years' time have efficacy more than 50% over 5 years' time. And so what we message is 90% of them need to restart the treatment in the year 3, but restart the treatment. In fact, you can achieve a similar efficacy for those who have started. The message is that if you have some child who has stopped the treatment, and then you can restart it, and then it can generate some quite good results. And another question we want to ask is whether atropine, low-content atropine, not just reduce myopia progression, can they reduce myopia onset? So this is a LAM2 study that we have done. We recruited about 500 children who are all non-myopic children without any myopia, and put into a randomized control trial into 0.05%, 0.01%, and placebo. Here you can see that, in fact, in all the time point, at any time point, 0.05% atropine is better than 0.01% atropine is better than the placebo group. And 0.05% atropine can roughly achieve a 47 relative reduction in the cumulative myopia incidence, which 0.05% and 0.1% all has achieved a good tolerability. And we are not saying that everyone needs atropine for prophylaxis. And then the question is, who are those that we need to treat? Who are those we need to do the prophylaxis treatment? So in a secondary analysis, what we did is we look into the baseline factor, and then to find out what are the potential factor. Number 1, hyperopic reserve, and also parental myopia is important factor. And we also look into here you can see that when the concentration, the interaction effect, 0.05% atropine and 0.01% placebo group. Here you can see that, in fact, when you have a 0.75 diopter less, the effect will take in 0.05% atropine is much better than 0.01 and also placebo in reducing myopia onset. However, if it is more than 0.75 diopter, in fact, the efficacy is not that obvious. That suggests a potentially cut off for children who have both highly myopic parents, and when they are hyperopic reserve is only 0.75 or less, you could potentially consider an option to the parents whether they want to start 0.05% atropine for prevention of myopia. So some take-home message is low-content atropine is effective along a concentration-dependent response. There is no effect on cornea and lens power. There is an age-dependent effect. There is also a choroidal thickening effect. We see that atropine can induce the choroidal thickening along a concentration response. And also during the third year, we should continue the treatment. We stop the treatment should be at an older age, at a lower concentration. And at 5 years, the efficacy is pretty good. And also 0.05% atropine is also effective to delay the myopia onset. And those who need this treatment are those who have a high risk, low baseline hyperopic reserve, and high level of parental myopia. So I would like to thank my department and all the team for all this work together. And I would like to highlight that we are going to have our third Congress of Asia Pacific Strabismus and Pediatric Ophthalmology Congress in Brisbane. June 29th to July 1st. You are all invited, and please come to this meeting together. And once again, I would also like to extend a warmest invitation and welcome to all of you to come to Hong Kong in APAO 2026 in the February 5th to 8th. It will be just before the Chinese New Year. I promise you we will have an unforgettable stay in Hong Kong to enjoy the atmosphere and also the friendship and knowledge exchange. Thank you very much.